It's October 17, 2025. This is a Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. It's 1 week till ACR. We've got a big plan for coverage starting next week. But this week on the podcast, we discuss pediatric stuff, pregnancy stuff, diet and nutrition stuff. I'm going totally soft, am I not? Don't worry. I'm going to throw in a few double-blind, randomized kind of nonsense things for you just as well. I like this first report because it kind of addresses an issue that no one really has addressed in my mind, and that is with JAK inhibitors, you sometimes see creatinine bumps. You sometimes see some benign CK-emia, meaning occasional CPK elevations without any reports of myositis or muscle problems. So this is a small report out of Lancet Rheumatology, just published, where they studied 15 patients with active RA who were at risk for sarcopenia. A sarcopenia risk meant you had a high CRP, a reduced grip strength, some other evidence of weakness. There's one other criterion. And they were treated with a JAK inhibitor as a new therapy. 13 out of 15 had never seen a biologic or targeted synthetic. And they received tofacitinib in the usual dose. And they studied them at 1 month, 3 months, 6 months. They did before and after muscle biopsies. They looked at what's going on in muscle in JAK inhibitor patients. And interestingly, they found, not surprisingly, everybody got better by 1 month as far as their DAS28 ESR scores. But that at 6 months, they showed that muscle mass had significantly improved in these patients by 242 square centimeters. That was about a 4% increase in muscle mass. That was significant at 0.017. The increase in muscle mass, interestingly, was less if they were on a nonsteroidal. We'll come back to that. And they also showed a significant increase in serum creatinines. On average, they gave it in millimoles. I converted it to milligrams per deciliter. The median change was 0.06 milligrams per deciliter. Small but significant across the board. At the same time, while these patients got better, serum cytokine levels dropped, including IL-6, IL-1, and TNF. Interferon didn't change. I think IL-10 was the other one that didn't change. There was no change in CPK, myoglobin, LDH, and AST. So this says that by controlling inflammation, they increase their muscle mass. Now, is it because they controlled inflammation? They moved more, they got more muscle mass, and that's why they're doing better? But they also showed an increase in creatinine. And in this case, maybe the point is that increases in creatinine may be due to newly generated muscle. And then maybe at times you get an increase in CK for the same reason. It's a very low frequency event, as you know. I've never had to discontinue a JAK because of small increases in CK. Interestingly, being on a nonsteroidal with the JAK, did that give you better control of pain and inflammation, more activity, more muscle development? Interesting to postulate on why that happened. Nice report. Congratulations to those authors. BMJ this week had a systematic review telling you and proving to you the things that you already know and say to your patients. They did a meta-analysis and systematic review of 217 RCTs, 16,000 patients, looking at the effects of exercise on knee OA outcomes. And they showed pretty clearly, with moderate evidence, if not better, that aerobic exercise is the way to go, as exemplified by studies on walking, cycling, and swimming. There are other things that gave benefit that was more short-term, but the aerobic is what shined through in this study. So walking, cycling, and swimming, cycling and swimming is great for they got really damaged knees and can't do the weight load bearing that walking would require. But again, these are pretty strong evidence for the advice that you've been giving. This week I had a case of osteonecrosis, led me to look up osteonecrosis on my own textbook rheumatology.com. The causes of osteonecrosis include the ones you know and a few you didn't know: trauma, high-dose steroids, alcoholism, renal failure, organ transplantation, lupus, bad lupus, any prothrombotic state, including sickle cell and other hemoglobinopathies, radiation, pancreatitis, gout, I didn't know, pregnancy I knew, hyperlipidemia I wasn't unsure of, and Caisson's disease, decompression sickness for those of you who like to go deep, deep into the water and ocean. Okay. A pediatric study from JAMA looked at a surprising statistic, not necessarily rheumatologic, but it deals with cannabis. A study of basically young adults in the Journal of Pediatrics, almost 1,500 young adults. When surveyed, a quarter of them, 22%, claimed to use either cannabis or alcohol for sleep. What? Alcohol, the worst thing in the world for sleep. Cannabis, I thought not too bad, but this paper shed some doubt upon it. In their survey, 18% said cannabis was used for sleep, 7% for alcohol. There was some overlap there. And both of these substances have been shown to interfere with the quality of sleep or the ability to stay asleep. That's clearly what alcohol does, hands down. I'm not directly aware of cannabis affecting the quality or the duration of sleep, but they said so in the article, and it's JAMA Dermatology, JAMA Pediatrics. So for those who used cannabis in the last year, 41% said they used it for the purpose of sleep. It's a trend with the wider, more available use of cannabis, is it not? Another study on pregnancy and outcomes in the offspring was a cohort study of 1.5 million mother-child pairs, and they looked at the influence of antenatal exposure to steroids. And they found that if the mom took steroids between weeks 28, weeks 32 up to full term, there was an increased risk of respiratory and non-respiratory infections. And that lasted until the offspring, the child, was up to 21 years of age. The incidence rates here was 65 versus 40 per 1,000 patient years, and that's for preterm deliveries, and 30 versus 18 per 1,000 patient years for full-term delivery. So the use of steroids in women who are pregnant, according to this, may have a long-term significant effect in the offspring's risk of developing future infections. Now, most of these are nonsense infections. We're not talking about people with, meningitis and sepsis, right? They did not report that. Another pregnancy report was a single center report on 189 women with IMIDs. 131 RA, 29 SPA, 29 PSA. Live births were pretty good. Best for SPA at 90%. Next best for RA at 76%. Not so good, but up there, 70% for PSA. Preterm deliveries was 16%, 12%, and 7% for RA, SPA, PSA, respectively. IUGR, intrauterine growth retardation, seen in 31 of the 131 RA patients, but not seen in SPA and PSA. C-sections were seen or used in about a third. And I think that I like this information about how many of these pregnancies used TNF inhibitors during pregnancy. 12% of RA, you could do better than that, but 48% of SPA and 31% of PSAs. I think that outcomes are doing better as we've come to understand how to best control the disease in the state of pregnancy. Another report on ILD, we do know that about a third or more of non-IPF ILD will progress over time, which means that 2/3 won't, right? And in subsets, it's only as much as 40% that won't. But still, that's a high number. Not all ILD will be a rapid progressor with a 10% change in FVC in a year. So in this study, they assessed a number of different outcomes. It's actually a retrospective study, 10 European centers, 303 patients. A third, 37%, progressed as defined by a greater than 10% decline in FVC in 1 year. They came up with predictors for progression. Age, gender, BMI, FVC, and KL6, a new biomarker that are being used a lot by the pulmonologists, not so much by us rheumatologists. The 5 predictors were better than the biomarker KL6 alone. The 5 predictors had a 55% sensitivity, 73% specificity, and 67% accuracy. These are good things to look at in your patients with ILD. A study on vasculitis, a tertiary center, looked at their 147 GPA patients followed for 18 months, 55 deaths and 179 relapses. Think about that. 147 GPAs, 55 deaths, a third, boom, with 18 months follow-up. That's the mean, died, and 179 relapses in 117 patients. That's an average relapse rate of 1.5 relapses per patient. So the predictors of relapse and the predictors of mortality were about the same, about a twofold increase. The risk factors were age more than 55, being male, and elevated creatinine, and neurologic involvement or CNS involvement, either at baseline or development over time. Not good. GPA still is a challenge, but this could be old data, may not be based on more current, aggressive, proven regimens to better control GPA outcomes. PSA and psoriatic arthritis, a very large study, I think this was in JAMA Dermatology, showed that fibromyalgia, when present in psoriasis and psoriatic arthritis, is linked to greater complexity and shorter biologic survival. Retrospective study where the psoriatic patients, 61,000 of them, were matched 1-4 with 244,000 controls without psoriasis. The prevalence of psoriasis was about 50% higher than the controls, 1.45. It was 3.3%. I like to say that in the general population, fibromyalgia is 5 to 6% in my opinion, but this says it's lower. In psoriatic arthritis patients, when they looked at the presence of fibromyalgia, it complicated things big time. They needed more biologics. The biologics they did use had less survival. FM PSA patients 6 year survival versus PSA without FM 10-year biologic survival, and an overall increase, almost a doubling in the rate of switching required. Again, it's a bad actor when it's a cofactor. That sounds like the title of this podcast. I never know the title of the podcast until I do the podcast, and then something goofy I say becomes the title. It's a bad actor when it's a cofactor. All right, look for that. Now you know why it's a title. Interesting things on nutrition this week. Scientific American, nice paper that you might want to give to your patients who are all into nutraceuticals. It's got a really well-written piece on the beneficial effects, immunologic and inflammation-wise, of omega-3 fatty acids, vitamin D, which I had to read because I got a bugaboo in my shoe about vitamin D, but it had good data in there about the immunologic benefits, and as you all know, curcumin. It's a good basic review that I would refer you to. 3 more reports. Again, our JAMA Dermatology had published the MEDISPO study. It's a small study, 38 patients, 16 weeks, with a dietary intervention being a Mediterranean diet. So half the group got a Mediterranean diet intervention with dietitian counseling for 16 weeks and a big bucket of virgin olive oil, and the controls just got a control. I don't know. What was it? I can't remember what the control diet was, but it was maybe like a low-fat diet or something like that. 38 patients, and almost all of them completed the study. When they looked at the psoriasis area severity index, the PASI scores at week 16, it was significant for the dietary intervention group, minus 3.4 versus 0 in the controls. That was significant at less than 0.001. The PASI 75 was achieved by PASI 75 change was achieved by 47% of those on the Mediterranean diet and none in the control group. Also on a Mediterranean diet, they had a significant lowering of hemoglobin A1C, and that was significant because A1C has been shown to correlate with psoriasis activity. Didn't know that. Had to read a derm journal to figure that out. A GI journal looks at IBD in the pediatric population and associated musculoskeletal symptoms. This is actually an Italian rheumatology and GI study. And they had in this study, I think the number was 111. I can't see it right. I didn't write it down. But they had a good cohort size of pediatric IBDs, 2/3 of them with Crohn's, 1/3 with ulcerative colitis. And of the musculoskeletal manifestations, 73% arthralgia, 69% arthritis. This article tells you a lot of things that you probably knew, but it confirms them, I think, in a good volumetric way. The other things that were important was inflammatory back pain in 26%, enthesitis in 11%, and dactylitis in 6%. No difference in musculoskeletal frequency between Crohn's and ulcerative colitis. Peripheral arthritis was much more common than axial, 77% versus 14%. The kinds of arthritis are the ones you would expect. Most of them, more than half, oligoarthritis, with a quarter each presenting as either monoarthritis or polyarthritis. Not unexpectedly, the main lab finding was acute phase reactants, sedrate, CRP, and fecal calprotectin elevated in 74 to 60%. And those acute phase reactants were more often higher in Crohn's disease than ulcerative colitis. Interesting. ANA positivity was seen in a quarter, and that was associated with a greater risk of extended chronic arthritis. Lastly, ferritin I found interesting because it was more likely to be low in this pediatric IBD with MSK symptoms than to be high. So I would think ferritin might be elevated because of inflammation. It was only high in 7%, but it was low in 32%. So that could be inflammation, that could be IBD-related GI bleeding, a number of factors. Anyway, I like that one. Last report has been teased at past ACR and EULAR meetings, telitacicept. Telitacicept, as you know, is the dual inhibitor of B cells by inhibiting BLyS and APRIL. Ron van Vollenhoven was the lead author on a study conducted in China in a phase 3, 335 active SLE patients who stayed on their background standard therapies. They received 1-to-1 either telitacicept or placebo as a once-weekly injection for a year. The year results favored telitacicept. The primary endpoint was an SRI-4 achieved in 2/3, 67%, versus 1/3 on placebo. That was highly significant. The 4-point reduction in the Selena SLEDAI was achieved in 70% on telitacicept and 40% on placebo. The downside is that there were more adverse events with telitacicept than placebo. Overall, 75% versus 50%. Most of those were nonsense, like URIs, right? But and they weren't. There was no statistic for that was meaningful for serious adverse events. But the telitacicept group did have more reduced IgG levels and IgM levels, 16% versus 1.2% for IgG, 15% versus 0.6% for IgM. And also the telitacicept had a 12.6% ISR rate versus placebo 0.6. So this looks good. And there was a phase 2 before this. And telitacicept has hinted at being effective in RA and also in Sjogren's. So its development is early, but it's encouraging. And we hope to see more data on this. You want to see more data? Follow us on Room Now next week. We'll be giving you some previews of what's happening at ACR, which starts a week from Sunday. I think that's on the 26th of October and goes through the 29th. We've got a big lineup, a lot of big reports. You be sure you follow us. My recommendations, if you want to stay up on what's going on the ACR, during your breaks, just follow the Twitter feed from @RheumNow. But if you want a daily kind of update, do the daily recaps. They're going to be at 5 p.m., I think, Central Time, 6 p.m. Eastern Time. Every day live streamed on RheumNow, on the website, on our YouTube channel, on Facebook, YouTube, and also LinkedIn and Twitter. So you can see that report every day of what was the highlight of the day for each of the 4 days. And then after the meeting, tune in and watch the video on the topic reports. We got a topic report on RA, a topic report on PSA and SPA. This year, a topic report on CAR T-cell therapy. What? Be there, be square. Talk next week.